Sorry about that.
No problem.
The only thing I would add to this great discussion is this question about biology versus social construct and social and equity, comes up. And there are, some specific examples where the susceptibility to disease really varies by race, ethnicity, but they're very few. And so I think we often include the possibility of differences in susceptibility, for example, as a hypothesis, but over and over again, we prove that that is the rare exception. And the rule is that it's structural factors, lack of access, and other inequities that lead to these differences in health outcomes. And so I think it's really helpful to highlight this as a construct, as many of these inequities have their roots deep in slavery and deep in our national history, and to call them what they are, which Dr. Cooper, you did powerfully, and I appreciate that. And it's important that we not sort of overemphasize the biological differences when we know that in the overwhelming majority of cases, these are really societally constructed health problems.
Absolutely. Thank you both for that. And this next topic in question is actually a perfect segue from what you all have just been saying, that physical distancing associated with slowing the spread of COVID-19 is a socioeconomic privilege. People are so pushed to distance and social distance, but it is a socioeconomic privilege. Let's discuss some of the effects of communities of workers who are not afforded the privilege to work from home, and unequal population shares of infection and death, as well as residential issues and familial issues of social distancing. And what are some examples of structural versus genetic conditions that contribute to these unequal shares? And by genetic, just, again, given what we were just saying, we know that COVID is not genetically, people are not predisposed genetically to something like COVID, but I would maybe say past medical histories or health disparities instead of genetic.
Right. So I think you brought up a very important point, and we've been hearing a lot about this in the media, not early on, but it became a much bigger story over time when people began to realize that, hey, there are still people out there working, even though many of us have been told to stay at home. There are people who actually need to go to work. They have to go out. They are driving buses. They are cleaning people's homes or other institutions. They're caregivers of other people, and they don't have jobs where they can stay at home and work. And so those workers are overrepresented among African-Americans and among Latino populations. And so we saw those people getting sicker at much higher rates, people who actually couldn't afford to stay at home, or they might have had hourly jobs as well, lower paying jobs, where if they took time off work because they suspected they might be sick or they needed to stay at home, they would not be paid, or they did not have paid sick leave. Many of them were uninsured. And so even if they did get sick, they would end up not being able to pay for their health care. So, that's how it began to play out. But we also know that because of policies, longstanding, this is what we're talking about, structural inequity, structural racism, longstanding policies have led to residential segregation in our country and have forced people of color to live in neighborhoods that don't have the social investment that other neighborhoods have. So as a result, the housing quality is poor. People live in more crowded conditions. They are not able to socially distance from one another. If there's a multi-generational family and one person has to go out and work, they could expose elderly family members who might be more at risk for getting sick. There are just multiple issues that prevent people from being able to protect themselves. They might not be able to afford to store up food for 2 weeks, so they might have to go out more frequently to do grocery shopping. Many of these communities don't even have safe water to drink, much less to wash their hands over and over again. So these are just basic things that many people would expect in the world's richest country that everyone would have access to, but we don't.
I agree with all that, and I would just say, it puts it in kind of a sobering perspective, as the Bureau of Labor Statistics has described that about 1 in 3 white Americans has a job that's amenable to working from home. And that's about 1 in 5 Black Americans and 1 in 6 Hispanic Americans have that same opportunity. So as Dr. Cooper said, right out of the gate, there's less opportunity to sort of retreat and have that benefit of social distancing. The other point that I would make about this relates also to policy. And so when we are having quite a discussion in the country now about masking policies. And I think what sometimes gets lost in this is that masking's, one of the primary benefits of masking is to protect others, is to prevent the spreading of the respiratory droplets around in the environment. And in states, including Georgia, where this has become controversial or politicized, this is detrimental to everyone's health, but it's especially detrimental to the health of people who work in those service industries who, when they go to work, will come in contact with the public. And so I think this is an opportunity really to call out and to recognize companies that have said, you cannot come into our store and shop in our aisles and interact with our cashiers unless you're wearing a mask. Because when those masks aren't worn, the effect of that disproportionately accrues to Black and brown people. And so I think that's another way in which these policies are calling into question or politicizing the wearing of masks perpetuates the inequities that should be of concern to all of us. The other thing that I'll mention, just to extend Dr. Cooper's point a little bit, is this idea of housing, but specifically housing density. So I had the privilege to work with Greg Millett, who is at AmFAR, on an analysis to try and understand how COVID is affecting predominantly Black counties in different ways from other counties. And one of the things that came out of that analysis was that the counties that had higher occupancy, so a higher percent of houses in which there were more people than rooms. So this isn't like a 3-bedroom house has 3 rooms. This is all the rooms, the kitchen, the bathrooms, the living room. And if there's a greater number of people than rooms in that house, that's associated with a substantially higher risk of COVID. And in fact, Greg's analysis described that at the time we did it in mid-April, there were about 750,000 COVID cases in the US. And this sort of occupancy in high density housing was associated with nearly 1/3 of those cases. And so to the extent that there's inequity in housing conditions, that can also drive the spread, presumably within households. And so these are just some of these features of the ability to social distance, either occupationally or residentially, that result in the inequities that we're observing.
Thank you to both of you. Those were excellent points, really highlighting both on a policy level, right? These historically discriminatory policies like redlining that have left certain communities, I would say, ignored and under-resourced, and giving them this real, lack of, sorry about that, giving them a real lack of access and availability to services. And it's this, it sounds like all three of us have experienced patient-wise and research-wise at this lack of resources, both financially and health-wise, right? And we talk about, well, I can't afford rent to live by myself, or, what have you, or I can't afford to store food for 2 weeks. I think those are excellent points that are really concrete, that are important to get out there. And that communities of color are suffering disproportionate financial consequences because of the pandemic, and this could be considered a pre-COVID situation, right? COVID has really exemplified that. And for me, I kind of had this image of viruses like those heat-seeking missiles that are just looking for the newest target. And when I said the dust is settling, it's this other image that I sort of have of, viruses looking for the most vulnerable. Mm-hmm. And with COVID, that was, in the media, Caucasian grandmothers. I think that was sort of the society, right? And now this is, not my personal research or research that I've read, but I see this shift. And now, you know, we have it really controlled with the nursing home, some homes better, I would say, but that Black and brown communities are being disproportionately affected. I see a sort of a pullback of people caring as much, perhaps. And, you know, at the beginning of the epidemic, there was this vernacular of calling it the great equalizer. And I don't know if the three of you grit your teeth as much as I did when I heard that, because we all knew that was not how this was going to roll out. Everyone's susceptible to COVID. It's in the air, it's on the surfaces, but we know this is not the case, right? No virus is going to be the great equalizer, because there's always going to be health disparities pre-existing.
Mm-hmm.
And, you know, I think that one specific thing, Dr. Cooper, you may be able to speak to this the best, but is that people talk about, you know, we think, okay, well, what are the most risky pre-existing conditions medically? We talk about diabetes, hypertension, obesity, all of which brown and Black communities suffer from disproportionately because of health disparities, right? Because of systemic racism in healthcare. So yes, these communities are more vulnerable in that way, but because they've been getting it from all sides to begin with. And, you know, it's important, I think, for all of us to know, to think about that these social determinants of health should be thought of as past medical history, right?
Mm-hmm.
Not just a family history of this or that.
Absolutely, yeah. I mean, it's a very circular thing, you know, when I would hear that, you know, people say, well, you know, are Black and brown people more susceptible to COVID because they already have these conditions? Well, you know, why do they have those conditions at higher rates? The reason they have those conditions at higher rates to begin with is because of the structural inequities. So they wouldn't be more vulnerable in that way if we didn't have the inequities to begin with. So it's kind of a circular thing to me.
Absolutely.
You know, and I've talked about in some of my other work, what I've talked about is the fact is we talk about herd immunity, and the fact that with an infection such as this, we need something like a vaccine where everyone can get protected against getting infected. But what I've said is that we actually need a new type of herd immunity in our country. And that type of herd immunity should be immunity to the negative social factors. So things like not having healthy food to eat in your neighborhood, not having access to a decent education or a job that pays you a living wage, you know, not having access to healthcare, or not being treated, you know, fairly when you go in for healthcare. That's the kind of herd immunity we need to develop if we actually want to have herd immunity to a disease like COVID.
I would just add, Dr. Pullen, when you were asking that question, the thing that I heard in the media, and I heard from a couple people who I had good discussions with, is the virus doesn't discriminate. And I think it's one of these, it's so short and seems so definitive, but really it needs to lead into a deeper discussion of that the virus doesn't need to discriminate. The virus is going to settle where the vulnerability is greatest. And the vulnerability is greatest in Black and brown communities because of discrimination. And so it's not a trait of the virus. And I think these sort of oversimplifications, and you sort of heard it in terms of the great equalizer, but I think it's exactly what Dr. Cooper is saying, is that it's the lack of sort of equity towards things that protect health, which might include nutrition and sanitary water and you know, access to healthcare. That's the reason for the differential impact. I just want to add that, you know, it's sort of also an oversimplification to say like the virus doesn't discriminate, it will infect anybody. But there's been some great work that just came out from Dr. David Holtgrave, and in New York, they looked across the population of New York State and asked the question, thought of this process as not just infection, but infection and then being diagnosed and then being hospitalized and then having an outcome of mortality, and how that varies across race. And so white New Yorkers were a little bit less likely to become infected, but once they were infected, were more likely than Black or Hispanic people to get diagnosed. Once everybody was diagnosed, the Black and Hispanic New Yorkers were more than twice as likely to be hospitalized, and then also had higher death rates. So it's really a series of issues about access to healthcare and outcomes that are not just about infection. So the infection data are worse for Brown and Black people, but so is each of those steps down the line. And those relate to social equity.
Well said by someone I admire greatly. David Holgrave is one of my role models.
Many of us.
Yes. Thank you both for that. I really, just to reflect that, you know, Dr. Cooper, your talk about herd immunity, my mind was blown about that because it was such a perfect way to you know, describe that. I think we talk about herd immunity as the holy grail, right, for virologically speaking. And I think that that's a hugely important concept. And I hope everyone here can bring it back to their clinic or their friends or their family, that concept of it's not just about, you know, virologically speaking, it is about the bigger picture of this. And, you know, Dr. Sullivan, I am fascinated by, as you said, this sort of trajectory from diagnosis to death, right? It's not just about the numbers can be deceiving. Well, you know, these cases are like this, or these people are getting tested. But, you know, I look twice a day obsessively at the Johns Hopkins site for that tracks COVID. And, you know, it's interesting what states are reporting testing by race. There's a few different things you can click there. And I believe, you know, that really is, if you're looking at preventative care, we need to know which neighborhoods are not getting access and are not getting paid attention to, right? New Orleans Department of Public Health has done well with this. They were realizing COVID was affecting their African-American communities more, yet their testing sites were not really accessible by those communities. So they went ahead and moved some testing sites. And so that's a very concrete example of what we can be doing. And we're seeing in California and Texas right now, especially Latinx communities being really decimated from, again, that trajectory from who gets diagnosed, who gets sick, and then who ends up dying, and looking at the proportions from that. So
right.
Thank you.
Yep, we've looked at data maps actually showing where the infections are and where they're growing, and overlaid it with where the testing sites are, and they do not overlap significantly. There are a huge number of testing sites in areas where they don't appear to be needed, and almost like non-existent. You know, when we looked at maps, for example, we looked at maps of New Mexico, Arizona, where we are seeing like an explosion of cases among indigenous people in a certain part of the state. Absolutely, like no testing facilities there. So the disparity, as you mentioned, Dr. Sullivan, is at multiple levels.
And I just want to add on that to say that I think there's also an issue with our initial response. A lot of initial public health response was to drive through testing. And I was working at the Fulton County site, and there was a guy who came through with the cars walking. And when he came up, he had gotten in line, and he had walked from a homeless shelter. And so it just made me realize that the focus on driving, I mean, driving is driving your car through a testing site isn't a socioeconomic differentiator right out of the gate. And so I told this guy, you know, that I was happy that he had come through the line on his feet since he didn't have a car to get tested. But that's really the fact that we asked people to do that as a way of testing. And so I do think that there have been more steps towards making testing more accessible. But that first wave of response was like, let's just have people drive through. And who does that leave out? It's along socioeconomic lines, but also along housing stability, mental health, and a number of other dimensions.
Yeah, I think it relates to a lot of the things we do, a lot of the decisions we make, not only in health and healthcare, but also about a lot of other things in our society. It has to do with who's at the table and who are the leaders as well. And so if you have people who are making those decisions who have no understanding or appreciation for what it's like to not have access to those things, they don't factor those things into their decisions. And they may not be doing it intentionally, but it just is not a way of thinking. And I think that's what we need. We need to look for leaders and elect leaders who will think, how is this decision impacting not just the people I know or the people who look like me, but everyone in my community, particularly the people who are the most vulnerable.
Absolutely. Today I was driving through Atlanta, and you get off the highway and there's a exit of Memorial Drive, Dr. Sullivan will know, and there's a good sized tent city of homeless people living there. And I saw 5 people that I counted coughing, bent over coughing. You know, and I had this fear in my heart of, I thought, well, I'm sure there are testing sites for the homeless. Are there? You know, and I think that it's a moving target, right? Any virus, but COVID now especially is a moving target. And, you know, it is important to keep abreast of that. And, you know, I would add, in terms of building and maintaining trust in healthcare providers, is that it's everyone's job to address our own implicit bias. You know, that's a term that's thrown around a lot. And people say, well, I don't tell racist jokes. I'm not racist, right? But it's so deep, you know, it's so deep for all of us. And none of us are immune to it, talking about herd immunity, right? None of us are immune to implicit bias, no matter who we are. And patients absolutely know that, and they absolutely pick up on that. So, you know, I would say, in terms of not just addressing patients' issues, but our own issues, our own bias, and getting the resources that we need for that, are reaching out to that. Also, I would like to say medical interpretation services are for patients who need them. As someone who works closely in Latinx communities and is bilingual, I see, I mean, it's chilling amount of patients who are not going to the ER, you know, who are not getting care simply because they feel like they won't be understood. And that's another major issue with testing, I would think, as well. And, you know, just promoting a trusting relationship. I know, back to the chronic pain, no one believes me. You know, I think one of the most important things we can say to our patients is, I believe you. We're both here in this room because I believe you. So having that off the bat, you know, if patients say to us, no one's going to believe me, or no one's ever believed me, but to promote that relationship with our patients and with our communities of trust, you know, or if people say, this is going to sound crazy, I always say, well, I've heard crazier. No matter what you're going to tell me, I've heard crazier than whatever you're about to say. So I think there's that, just on a really human level, to promote trust. And I'll share a quick vignette. Dr. Vince Marconi, who's one of our just incredible physicians and friends at Emory, he said something to me. He's been a great mentor to me. And he said, you know, when he does telehealth with his patients, he says, before we start, show me around your house. Let me see what, you know, tell me where you are right now. Do you have any pets? Show me about, you know, who's in your house. And just to kind of set the stage of equality with patients, and not say, I'm the white coat and you're the measly patient. And I really love that concept, especially now with the major disparities we're seeing, just to kind of set the stage with our patients, that, or our community members, that we're all on the same level with this.
Yeah, I couldn't agree more. I mean, I think one of the silver linings in the cloud of COVID-19 is, if a patient can actually get access to services where they can have a telemedicine visit, then it gives us a little bit more of a window into their home and, you know, their immediate environment that we might not have had otherwise. Of course, there are all the other barriers to people actually having access to telemedicine. So, you know, we know that there are a lot of Black and Brown people, people with low income, who actually can't really right now engage with us using telemedicine because they don't have broadband internet, or they don't have the type of smartphone where they can actually do that. So, you know, we've got that challenge to deal with. But that, I would say, that is one of the silver linings in the cloud. And you know, what you were talking about, Dr. Pullen, is very interesting. You were talking about two things that I've written a lot about and studied about when we talk about addressing health disparities. And one of them is relationship-centeredness, which is all about, like, who we are as health professionals, how aware we are of our own attitudes and our own biases, how we communicate with our patients and, you know, the people that we serve, how we work with each other from different backgrounds within our settings, how we relate to our community. But then also, it's about structural competency. And that's the degree to which we're aware of social injustices and health inequities, and the degree to which our actual systems are set up so that they meet the needs of people more appropriately and more sensitively. The fact of whether we actually are resourced appropriately in settings that provide most of the care to Black and Brown communities, you know, and whether or not our workforce is representative of those communities. So those are sort of more the structural factors. And then the relational pieces are also important. We need all of them. We need them at multiple levels.
Absolutely. And I would add also that our medical training facilities, our medical schools and our training schools have representation of our patients, the patients that we'll be seeing as well as educators. Absolutely. Well, let's move on. You know, I think that, you all have set the stage really well about pre-COVID, right, conditions, and then current conditions right now, where we are, where we came from, where we are now. And let's move into the future now. So, where do we go from here, given everything we've said leading up to right now? And I'd like to talk about long-term clinical effects from COVID-19 and existing health disparities. Where do we see the intersections of those? And how can we better care for our marginalized communities in this context?
So I don't know, I've been talking a lot, but I'm happy to jump in, but do you want me to?
Yes.
So I think part of it is actually some of this digital divide that we were just talking about, is making sure that that with this sort of shift to more telemedicine approach to healthcare, that we are not leaving certain groups of people behind. I think it's going to be really important for us to focus on that, on making sure that we enhance that access, and we also enhance what we call digital literacy, people being able to actually take advantage of that technology. I think there really is going to need to be more of an investment in preventive and primary care. If we focus all of our resources, as we tend to do disproportionately in this country, on sort of tertiary care, we miss out on the things that we could actually intervene upon earlier to prevent the later complications. So I think what we probably are going to see as a result of a lot of people having worse access to care during this time is we're going to see a lot of people with chronic conditions that have gotten worse because they haven't been treated. So we really need to make sure that there's a strong focus on addressing care holistically, and expanding access. Really, this whole business about the question of removing insurance coverage from people is just out of the question, if you ask me. We have to expand access further, so that, especially in this time when people have lost employment, so making sure that everyone has health insurance so that they can get preventive and primary care. I think that care management programs that actually help to address continuity of care, chronic conditions that also bridge between health systems and communities. So thinking a lot about using community health workers, lay workers, supporting caregivers outside of the healthcare system, better addressing social needs and not only focusing on medical needs. I think this is really where the healthcare system needs to place its focus at this time. And really, and that, the resources need to be distributed in a way that those systems that are less resourced actually receive more of the support right now. The safety net providers, talking about the community health centers, and the places out in rural areas that actually need more support now than the high tech, sort of already well-resourced areas. So any of that, funding that comes out from the federal government, we need to make sure that it doesn't only go to people who sort of are already doing fine.
Absolutely.
I just like to make that call a little bit even more specific, which is we've been talking about, and we actually started out talking about today, the relationship between lack of health insurance and other kinds of health inequities. And specifically, we need to keep talking about Medicaid expansion. Honestly, it's a topic that never gets stale, and it's no coincidence that a lot of the southern states that appear as red in your Johns Hopkins map or in your nightly news maps in terms of being states with emerging and surging epidemics are also ones that still have the opportunity for Medicaid expansion. And a period of emergency enrollment for the Affordable Care Act. We also should just continue to call for that, because we need healthcare more than ever now, and our society needs people to seek healthcare when they need healthcare both for individual health benefits and for community health benefits. So those two things I think are squarely on the table. I also really appreciated Dr. Cooper starting with the digital divide and how that might influence access to healthcare. Again, I feel like we're talking about bigger societal issues because these disparities grow out of bigger societal issues. But I would just say that the other consequence of lower access or less opportunity to sort of digital interactions is also economic. And I think as we emerge economically from this crisis, that those without the ability to interact electronically may be at a disadvantage in terms of job interviews or in terms of types of work. So these inequities in technology access and bandwidth access may perpetuate that. And then the last thing that I want to mention is that as people go back to work, I think it's more important than ever to identify those aspects of testing programs that actually encourage people to test. And I'll say without naming that I had the opportunity to work with an employer in Georgia where we were doing health screening in an industry that has a highly affected workforce. And what this employer did was encourage testing. And so we were very concerned about how voluntary that testing was and who would see the results. And the employer let us know, and then the employees confirmed that they had been told that if you test positive, we are going to send you home and pay you. And if you have a sick family member that you're caring for, we're going to send you home and pay you. And we're going to offer you testing before you come back. And so if you think about from an economic point of view and from a workplace practice point of view, we need to think about how to encourage testing that actually supports people to get tested and then get well. And I think that there are shared wins here. And the particular employer that we were working with, I think, has the benefit that their workforce now is encouraged to stay home, get better, and retest before they come in, and they can maintain a workforce in that setting. And so I think doing testing in a way that encourages people to test and supporting people who are found to be living with the virus to recover and care for themselves and their families makes good sense. And this is something we need to pay attention to as people start going back to work so that people don't resist testing because that might have economic consequences. And again, the denser the workplace, the bigger effect this is going to have where people don't have individual offices. So thinking about what that next phase is and what best practices are.
Thank you to you both. Those were such excellent ideas and thoughts. You know, Dr. Cooper, I appreciate all of the spectrum. I feel like this conversation has been great about the spectrum from individual patient to federal response. And you're able to really succinctly tie those into two little bookends. And that's, thank you for that. And, you know, Dr. Sullivan, I really like what you said about this specific idea in terms of testing. I mean, you could call them incentives, right? But it should just be the norm. Because that is the case. I know of people who would not go bankrupt necessarily if they'd missed work, but are, you know, I've heard of people socially and clinically saying, well, my roommate tested positive, but I'm just going to wait because I don't want to take my days off, you know, spend my PTO. And I really cringe to think about that. And I think, you know, economic realities are economic realities for people, but it's a massive public health threat, and people are weighing that against survival right now. You know, and we'll wrap up shortly, but when I think about long-term COVID, talking about long-term clinical effects, you know, it was really years before we knew about the concept of HIV and aging would exist, right? At the HIV and Aging conference last October in New York, there was a physician speaking that he said, I never dreamed that I would be at HIV and Aging conference, and I couldn't be happier to be here. You know, and right now, it again is this moving target of what will long-term COVID recovery look like, because we don't really know still what the long-term effects are. It's evident that there'll be pulmonary and physical endurance, bodily pain, weakness, as well as a number of other things that will likely be long-term, maybe lifetime effects for people. And I think, you know, in my experience and from what we're all saying, that this collaborative care is necessary with the patient with an equal seat at the table. right? I see this at the at the Ponce Center, which is the AIDS clinic in Atlanta, that does an excellent job of that. The patient has an equal seat at the table, and that supporting people in this progressive treatment plans as they regain their strength and endurance and functional independence, and also to really focus on, for all of us in medicine and public health, academia, that to fully address all aspects of recovery, not just the pulmonary effects, not just the muscle weakness, right? And that we have to see health disparities and institutionalized racism and social determinants of health as equally important pre-existing conditions. Whether or not someone was obese beforehand is important, as well as if they lived in poverty, as if they had suffered from this, historical generational poverty and racism, and that we have to take all of that into account and into consideration to our recovery efforts for our patients and our communities, and for us also as providers as we move through this.
I agree, and I was just going to say that I think one thing that will help or should help to connect us all during this time is the fact that we do, to some extent, have shared vulnerability right now, even though some people might be at greater risk than others based on social circumstances. The truth of the matter is that we are all at risk, and that, any one of us at any point in our lives might be at risk for having more struggles socially. We might not always have the money we have. We might not have all the people around us in our lives to take care of us. Or we may become older and become frail and need, extra help. So I think the more we can get people to see the connectedness of this problem and the fact that it's a human problem that we kind of all share, and the fact that if some of us are not doing well, it has a negative impact on all of us. I'm sure you all would agree that watching these horrible statistics on TV and hearing these heart-wrenching stories and seeing these violent protests against police beatings, those things are having a negative impact on all of us, not just the people who are actually the ones experiencing it. So the more we can sort of see that interconnectedness and see how these social conditions actually do have an influence on health, that health is not only about like our individual behaviors, that's one part of it, but it's also about all the other opportunities around us and the opportunities that others around us have. The more we can get people to care about those things and see the connections between them and actually advocate for change, I think that there's hope.
That is such a high point that I'm going to suggest that be the last word. I got nothing else to say. Thank you.
Absolutely. Thank you so much to Dr. Cooper and Dr. Sullivan. This has been really inspiring for me personally and professionally to hear your words. We do have about 5 minutes left. And Marche or Elaine, if you want to hop back on, or I can also, there's 2 questions that I can read aloud.
Yeah, thank you so much, everyone. This has been wonderful. I think we have time for a couple of questions. We had a question that came in a little bit earlier talking about the population in correctional facilities and lack of access to testing. Have any of you done any research in the correctional facilities and that population transitioning back into the community?
So I personally have not. I have colleagues who have, but I don't know, Dr. Sullivan, have you?
I have not in COVID. I did a 9-month-long cycle of work in the Georgia State prison system around an HIV outbreak some time ago. And I think that the lesson that I took from that is one, that in working, it was a process of working with correctional officers to get buy-in, but that there are really great opportunities to promote health. I think part of what needs to drive better screening and surveillance programs is to have some ways of testing that may be easier to make available in these kinds of settings, meaning saliva testing, for example, that may be less invasive or maybe easier to let people self-administer. But clearly it's just another example of the concentration of people with more socioeconomic disadvantage, and we have to expect that increases vulnerability. And I think we have to, hold ourselves to a level of innovating however we have to make that kind of testing and programs work in those settings. But there are definitely challenges, I think, when it gets to medical procedures and doing that at scale.
Great, thanks so much. You all have touched on this a little bit before, but could you speak a little bit more on recommendations for access, providing more access for telehealth? If there's any community outreach that you all know of, or any way that that's being facilitated and really spread more into community?
So I know that there are some telecommunication companies that are working pretty closely with communities to expand access at this time. I do know that there are community leaders that are working very hard on this issue, expanding access, making it more affordable for people. Also, teaching older people, teaching people who don't know how to use technology, using actually more the sort of simple methods. But so there are some community-based organizations that we partner with that's their primary focus is digital literacy and digital access. So I know that there are efforts being made.
The one thing that I'll note about this is, telehealth, I think, and our physicians can say more about the visual component of it. And I can imagine as a clinician that you may want to see affect, or you may be able to see, different aspects that are visual. But my colleague Erin Siegler at the School of Public Health runs a digital or telehealth prep program, pre-exposure prophylaxis for HIV, and is reaching into rural areas. And one of the concerns is just that the bandwidth there, the telephone bandwidth, is lower. So even if folks just have a cell phone in most urban areas, that will support video streaming, but in rural areas, not. And, it sounds simple, but in some places, they complete everything they need to do just with a telephone connection and mail in specimens, for example. So I think there's that whole range of thinking creatively, not just about the video-based aspect of it, but about ways we can connect with people. And again, I'll leave to the physicians like what might be able to be done with and without a video connection. But I think thinking of this broadly as an opportunity, and I do hope that COVID at least opens up the door on the part of insurers and on the part of institutions to thinking about this when it's a good alternative for people to commuting as a way to engage in healthcare.
I think that's really important because, and I do think that, the visual component is important, but I agree with you that a lot can be done over the telephone. And I think those of us that provide care to underserved communities would really like to see policymakers allow people to be able to bill for telephone visits.
Exactly.
Right now, they've extended that courtesy through the COVID period, but there's some talk about the fact that it's going to be rolled back and it'll only be billable if there's a video component. And that's going to create problems for people who care for underserved groups.
Yes.
Absolutely. And I also, to add, this is a question, and also what I was going to say is that to not lose sight of our other resources that we would have in the hospital or clinic, like interpreter services. So telehealth and phone calls and video calls do rely on people speaking the same language. So just to remember, one other thing we'll need to think about is, well, how do we get interpreter services to come along with us virtually on telehealth as well?
And we're doing that already, actually. I've seen that, but it makes care much more complex. I can tell you, when I looked at my schedule and I see that I have 6 or 7 patients who speak another language that are waiting to see me, and it's a telehealth visit too, I'm like, really, I can feel my anxiety level going up. So it's definitely adds a layer of complexity.
That's great. Well, as we wrap up, we've already kind of touched on some amazing pieces of this whole conversation. I would like to just end with each one of you sharing one highlight that you've seen with this whole, spotlight from COVID. What is one thing that you can share that you think is going to have a meaningful, positive change?
Well, I think I've sort of said this already, but I really feel like I see people coming together who normally wouldn't be talking to one another. We've gone to a lot of efforts to stay in touch with our community partners. There are colleagues of mine that I am working with now that I never worked with before, because they have expertise in an area that could be helpful to the patients I'm seeing or to the research that I'm conducting. And it's really sort of, I think, forced people to think more creatively and to do things in a different way. And I think that that is a really good thing. And that's why I'm hopeful.
Thanks, Dr. Cooper. I'll say just along the same lines that in our research world, which we haven't talked that much about today, that this has also forced us to ask ourselves questions about the other ongoing research we have and how it can be adapted to be more, to be less travel demanding, I would say, for our patients and research participants. And I do think along those lines that there may be benefits that come of this, this sort of forced move and people investing resources and exploring these opportunities. And I would just say, along the lines of what Dr. Cooper said, that I think this hopefully once in a lifetime or once in a century pandemic reinforces how connected we all are. And I think in some ways the discussion we've had really illustrates that vulnerabilities among any of us are vulnerabilities among all of us, and just how connected we are. And we can and should make the argument that healthcare, housing, and the kinds of social opportunities that we're talking about need to be made available as a matter of morality and conscience. But I think this also reinforces why we do better when we all get there together. And I think if we can re-articulate that and hold that forward as we try to do this work, maybe that message will stick.
Right.
Absolutely. And for me, there's been a silver lining of, for myself, being more open-minded about telehealth, and some patients do have video access and some just do a landline or a cell phone without a video. And I realized that I'm so much better able to work around, one of my patients has a newborn baby. I can work around the baby's nap schedule. I can worry, one of my patients just went back to work. I can work around his work schedule. So to really be more patient-centered in terms of their schedules, right? In terms of their lifestyles. And so for me, it's been realizing, a lot of the patients where I work, it's a extremely vulnerable population socioeconomically, health disparities wise, and a huge barrier to care is not being able to get to clinic. They don't have the gas money or they don't have the subway fare. And so really saying, well, what, this telehealth or phone health on the appointments where I don't need to actually see them in person, to be more open to that, to having that patient have that seat at the table and to be able to drive that.
That's wonderful. Thank you so much for sharing your insights. Our deep gratitude to all of our panelists for sharing your time and energy and expertise on this really important topic. We're excited to continue this conversation. The recording will be sent to everyone who has registered, and we'll also be sharing the emorycollective.com, where we're housing our ongoing digital conversations. Thank you again to everyone who joined us and to all of our participants. Have a great rest of your night, and I hope everybody stays safe.
Thank you.
Thank you.
Bye.